and documentation. Well, let's see what we have here. We're going to be, we have to take call, right? You know, the dispatcher calls us, you know, the tones go out. We've got a whole series of little hoops that we jump through there. So we're going to talk about the various stages of a call. We're going to talk about our radio communications. You know, we have a format specifically when you have to call the hospital to give a patient care report. We've got a format there. So we've got things that we're going to have to jump through there. We will give a report to the nurse or doctor at bedside. So there's a process that we go through there. We have to use our communication skills because we communicate with how many people on the EMS call? Like lots of people. So we're going to talk about how we're going to communicate with those guys. We also communicate with patients. So we have to be especially skilled at that because if we're not good communicators, we also won't be good what? Providers. We won't be able to do good assessments, we won't be able to do good treatment, so communication with our patients is extremely important. Then we're going to have to document all of this stuff, because if we don't document it correctly, we can be in a world of hurt. We don't have to testify very frequently, we don't go to court very frequently, but all it takes is once, and you're going to be going, oh my gosh, I wish I had done a better job. We're going to look at the legal aspects of that. And we're going to look at patient refusals. We've talked about those already. We're going to look at them again because it's so important. Oh, I thought I blocked that out. Good for me. Okay. Various communication systems. We have a lot more available to us now than we had when I started out years ago. We have radios. We don't really use pagers anymore. You may have a service that may page information to you about where you're going, what the patient complaint is, and that kind of stuff. But mostly I don't think they're using those anymore. They're using cell phones a lot. Calling the hospital, you may use a cell phone that is attached to your unit. I don't mean physically attached, but goes with your unit, where they will send you the dispatch informations. And then sometimes we actually need to use a landline for different reasons. Can you think of any circumstance where you might need to use a landline if you don't have their address?
No service on your cell phone?
Yeah, no service on your cell phone is a biggie, certainly. And sometimes you need a really private conversation. And so, you know, like now I'm a Verizon customer, so you know what that means, right? Yeah, the government's interested in who I'm talking to. And so I have to be concerned about protected patient information now, so they're snooping on my phone calls. It's a little scary. But anyway, with the landline, then you can have more private conversations sometimes. You may need to do that. For instance, say 911 gets a call for a possible bomb at an elementary school. Would they want that to go out over the airwaves? Whoa, what would happen then?
Panic.
Yeah, panic. You're exactly right. So they may call you to go stand by with police at whatever's going on, but they're probably going to call you, dispatch that out, and they'll say, would you please call dispatch? So then you'll go to a landline and call dispatch. Okay, our radio systems consist of a lot of different working parts. A base station is going to be, base station may be where the dispatch center is, where they call you. The mobile radios, we're going to look at portable radios, repeaters, microwave transmissions, which, are any of you guys like really into communications and radios and all that kind of stuff? Is that anybody in here? Okay, so if I say it wrong, nobody's going to know? Is that what you're saying? I'm not sure what microwave transmissions are because my microwave doesn't transmit anything. But little sounds. Digital radio signals. So to this, I have figured this whole photo out here. If you live in a rural area where you have a large service area, it doesn't necessarily have to be a rural area, but a large service area, the amount of energy that you can transmit from a portable radio isn't enough to reach the base station. So they put up repeaters. And this is kind of the way it goes. You got the base station. Say this is what puts out, this is the dispatch center. So it's going to either call or use a radio to dispatch you. Now they may have a separate dispatch center, or this could actually be the hospital, could be a base station, depending. So anyway, it's going to send out the information, and it will. Let's try to do this here. I don't know why it's pointing here. It kind of goes out. It's going to hit a repeater, and from the repeater, it'll send it out to the EMS unit. It may send it out and hit other repeaters, so you can actually get to your handheld radio. So, for instance, when the dispatch center dispatch you to a call, they're going to call on wherever you are. You may be in here, or you may be out somewhere on your portable radio, but they've got to be able to reach you wherever you are. So that's why you have these repeaters to boost the signal. Let's see if I can find some better stuff here. We'll get back to that. Your textbook, I think, breaks that down pretty clearly if you'll look at it. It differentiates the amount of watts or energy that's associated with each one of those devices. Like, which one of these do you think is going to have the longest range? Yeah, your base station. It's going to have the strongest signal. What's going to have the weakest signal? Yeah, it's going to be your portable handheld radio. And so this is kind of a moderate signal that you're going to get there. Okay, radio communication in EMS service is going to be regulated by the FCC, Federal Communications Commission. They assign frequencies. If you ever see those broken down, fire department has certain frequencies, EMS has frequencies, EMA, emergency management, has a certain set of frequencies, police has a set of frequencies, so they all are operating within their assigned frequencies. That's one of the reasons that a few years ago all the television stations had to switch to digital, because they didn't have enough bandwidth for all the emergency communications. You know, as the population grows, they need greater bandwidth. Plus, one of the other things that was on the table at that time was, particularly after 9/11, they found that they really were not able to communicate between all the agencies like they needed to. Fire department was not able to communicate straight across police without going through dispatch. Same thing, you know, with EMS and everybody else. So what they did is they established common frequencies that all of those agencies can access. So when they did that, they had to knock some of those television and radio stations, particularly television stations, off of those other frequencies and put them on digital. But they, FCC monitors the emergency traffic, and we'll talk about that in a minute when we're talking about, well, here it says, establishes rules regarding appropriate language. You know, if you're, like, the radio and television, they can't, like, there's certain words they can't use on television. Same thing here. There are certain things you certainly don't want to use over the airwaves for us. Okay, when you are talking on the radio, you want to make sure, well, number one, that your radio is on. Don't ever get off of your ambulance with your radio without turning it on. Doesn't work. It's kind of like the AED. We're not going to be able to defibrillate anybody if we don't turn that thing on. We're not going to be able to assess our patient without turning that thing on. So you got to have it on. You got to have it adjusted appropriately. When you're talking on the radio, make sure that there's not a whole lot of background noise. You know, if there's background noise in here, at least we have other senses. You know, you can see, you can watch, you can hear, you get a feel for where the sound is coming from. When you're talking on a radio, it's very flat, so it's very easy for background noise to interfere with your transmission. When you go to use your radio, to speak on the radio, you need to make sure that the frequency is clear. If you hear talking coming out of your radio, then that's not the time to get on your radio, because only one person can talk at a time. It's not like on the phone where, you know, you can talk back and forth. With a radio, as soon as somebody keys up and starts talking, they knock everybody else off the frequency. So before you start talking, make sure that it's clear so that you can talk. Now with the radios, it's called press to talk. You guys got that? What is that other? What is it? The Southern Link, where it's a little press to talk thing. Do what? Walkie-talkie. Yes, basically like a walkie-talkie. You have to press that button in order to talk, but you got to remember that we're using repeaters, so it has to bounce from one site to the next. So you need to press that. You need to wait at least a second before you start talking, because what happens is if you push and start talking, by the time the person on the other end hears it, you've cut off your first word or two. And that could be extremely important, like, don't go to blah, 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 blah. And all you hear is, go to blah, 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 and off you go. So sometimes it's important that those first words are not cut off. So you want to press it and then wait a second or two. What I would usually do, I'd press it, then I'd take a breath, and then I'd start talking. That way I knew I was, in time. Now, have you ever heard the preacher or anybody where they're way too close to their microphone and they're talking like this, and it's all. Make sure you don't get the microphone too close to you so that you're projecting properly. Use unit names and numbers. Be very careful about sounds where one sound sounds like something else. I had a call years ago when I just moved to a new area and I didn't know the area, and the dispatcher says, I want you to go to Atlanta Street for cardiac arrest. When you hear cardiac arrest, you know that's pretty important. And I'm going, 378 Atlanta, and we're looking in the book, and I'm going, the guy I was working with didn't know the area either. And we kept looking for Atlanta. I couldn't find Atlanta anywhere in that book. And I called the dispatcher back and said, can you repeat that? And she repeated it again, and it still sounded like Atlanta. And finally I said, I'm really sorry, I can't hear. Can you spell that for me? Well, it was Volanta. She was saying Volanta, which I've never heard of. You guys ever heard of Volanta? It's in Fairhope. It was in Fairhope. So anyway, Volanta. So the guy had been dead for a while by the time we got there because I couldn't understand her. Couldn't find the place. So make sure you understand exactly what it is. The dispatcher should be good about being very clear. And if you're not sure what they said, make sure you ask them. When you are calling on the radio, you want to say your unit. You want to, as you break in, you say this is unit 378. You want to wait for them to respond so that you know that they're listening to you. It's kind of like when you call the ER to give a report and, so-and-so answers the phone, this is community hospital, and then you say, hey, this is unit 378, we're en route with a 57-year-old female, she's got chest pain, blah, blah, and you give this long report, and then she goes, can you hold on just a minute? I'm the tech here, let me get a nurse. And you're going, so make sure that they're ready to listen to you. So that's what you're doing here. You say, this is 378, and then you wait, and they will recognize you, and they will say, go ahead 378 or stand by or whatever it is. So you want to make sure that they're listening to you before you start talking. Speak slowly and clearly. This is a time you want to enunciate. Just like when your mom would tell you you're slurring your words or you're mumbling or something, this is not the time to mumble, or you're going to end up on Atlanta Street when you need to be on Volanta Street. Keep it brief. Recognize that when you're on the radio, nobody else can get on. So if you're in there, blabbing on about something that's not important, you may have another unit that has a really big emergency and they need you off the radio. So give your important stuff and get off the radio. It's not a time to socialize. We use plain English in EMS now. In the olden days, we used to use the 10 codes and all sorts of signals, signal 27, and you had this long list of things that, and a lot of places still do that, and they really shouldn't. Can you think of any reason why you would not want to use all those signal 37, this is a signal 80?
Like 9/11, people had all these codes, and their codes don't match.
Yep.
Your police codes don't match your fire department codes, don't match your EMS codes.
You're exactly right. And I moved up here from Baldwin County, which is the largest county in the state, so it was huge. So we had our codes for our county, and it wasn't a problem. But you look in an area here like Lee County, and I still haven't figured it out, we are touched by about 5 or 6 different counties. And I mean, I can't go from here to the state line without crossing through 5 or 6 counties. I always look up, oh, that county, oh, that county. So if each county has their own set of codes and you're constantly crossing over county lines, nobody knows what anybody else is saying. So if you got people and then other agencies, like for hurricane, we brought in a lot of other services from around the state and even outside the state that would provide coverage down there, and we need to be able to talk to them. So we're using plain English instead of codes whenever possible. you don't need a lot of unnecessary words. You don't say please and thank you and, oh, thank you for giving me that information. You always want to be polite, not rude, but don't spend a lot of time with superfluous information. You never need to say be advised. I don't know if you've heard people say that or you hear it on the radio, but it's very rude. It's like, be advised, blah, 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 blah. It's like, what? So that's rude, so don't say it. Also, please, thank you, stuff like that. If a number might be unclear, say the number and then repeat the individual digits. You know, you'll all find that there's some phraseology that's more challenging for you. It's kind of like writing out the amount of a check. You know, it's like this long. 1942 is 1942. Sometimes you might want to say 1942 to make it more clear. Be very careful about your patient's privacy. You never want to use a patient's name on the radio. Particularly in small town areas where everybody knows everybody, you know, just by virtue of saying the address, oftentimes they know exactly where it is, but you add on more information like their name and you don't want to do that. Be very careful. Don't use any profanities on the radio. You know, the dispatcher calls you, they're sending you to Mr. Jones, who you've been there 5 times this week, and it's always for the same thing, and you never transport them. You know, you may want to use a superlative or something, something you probably shouldn't say, but just make sure you're not on the radio when you say it. You don't want to slander anybody or anything, say anything inappropriate on the radio. And I want to caution you too, even though you're not on the radio, you don't want to get in the habit of saying that kind of stuff, even when it's just you and your partner in the truck, because things happen. It happened to me. We had run a really bad cardiac arrest, and for whatever reason, the people that were there responding with us were like clueless. They were like chickens running around like this, and not very helpful. So we were sitting outside the hospital, and we were discussing that, and I said something I probably shouldn't have said, and about a minute later, I get a call on my cell phone from the dispatcher. He says, you might want to check that mic, because you have a hot mic. You just told everybody in the county about what that service did. And I went, oh my gosh. And sure enough, my partner had hung up the microphone, but then he crossed his legs across his knees, and he was pressing on the button. So we had full coverage for the largest county in the state while I said that those people were. I didn't say anything vulgar, but it wasn't very nice, so I was embarrassed. So anyway, so be careful about even doing that in the truck. And now these days too, they've got lots of cameras and microphones in there where they automatically record certain things, like if you jam on your brakes, the recorder comes on, and oftentimes it'll show what's going ahead as well as what's happening inside the cab of the truck. The big services all have those. In the event that you're involved in an accident, they can recreate that. And if they see that you ran a red light because you were like eating Cheetos or something, you're really in trouble. So know that that stuff is on. If somebody hits the brakes too fast or you take a curve too fast, sometimes that will activate those cameras, which many times also have voice recorders. So, you know, if you're about to run over that curve, you don't want to yell, you know, profanities. But anyway. When you're communicating, you want to say, we are en route, not I. Affirmative and negative sound much better than yes or no. I was just talking to a guy on the phone yesterday, and a couple of times he goes, nah. I'm sorry, was that a yes or a no? I'm not sure. So affirmative and negative is completely acceptable on the radio. After transmitting, you may say over. I've never heard anybody say over, but they say you should say over. When you're done, you're just kind of done. No slang, no unauthorized abbreviations. We talk about ETOH. Somebody know what that is? So a patient's got ETOH, usually indicating they've got some kind of alcohol that they've been taking. Be careful about using those even on the radio. Oh yeah, that patient's got some ETOH on board. Yeah, we'll save that for private. EMS frequencies for authorized EMS communications only. Even if you have a TAC channel, another channel, secondary channel that you use that just goes among units, just be careful what you say and keep it strictly business. It's kind of like your email. If you're working somewhere, you have your work email account, and then you have your personal email account, and you shouldn't be crossing those over. If 2 units are transmitting simultaneously, they're only going to hear one. So whoever's got the stronger signal there is going to override. And you may spend 5 minutes talking on the radio before you find out that not a word got through because there was another unit that was a little bit stronger than you. Dispatch will usually let you know that they've heard your transmission. You know, they will copy you. So unit 378, a copy that, or clear, whatever it is. So listen for that. If you don't get confirmation that they heard it, you may check back and say, I'm just checking, did you get my transmission? Yeah. Usually the dispatcher will give you a time. Just about every time they talk to you, they give you a time. That's just what they do. When they dispatch you to a call, they'll say, Unit 378, want you to respond to 374 Armstrong Avenue, time 2242 or something, I don't know. So that you could document that. But that's, everything they say is taped. So if you call them, everything's on a recorded line. When you call the emergency department, everything's on a recorded line. So everything is time stamped. So you want to actually line up your watch with the dispatch time when you go to work in the morning or the evening, so that you're always on the same time. But they'll be giving you the time throughout the day. Anytime you leave that ambulance, you should have your portable radio with you. If you get out of the truck, take that radio with you. If you happen to be in a service that only assigns one truck, I'm kicking up one radio. You want to kick up a hissy fit because every person on that truck needs a radio. If you get separated, if there's a problem, everybody needs a radio. So do not get out of the unit without a radio. I had a partner one time, we went to a plane crash and it was way out in the woods somewhere, and as soon as we parked, he ran out of there like a shot, and he hiked in about a half a mile to where this plane wreck was, and I'm standing there with my radio and his radio. So what's going on now?
You don't know where to go.
Yeah. Don't know where he is. I don't know how many patients he's got. I don't know the status of those patients. I don't know what equipment he took, which he took nothing. Nothing. If he'd had his radio, at least he could tell me what was going on. We could call the backup or whatever he needed. So always make sure when your fanny leaves that seat that you have a radio on you. Make sure your radio is serviced, that it's charged, it has enough battery. You don't want to be hung out there somewhere and your battery goes dead. Okay, you have to make a radio report after you have treated your patient and you've gone en route to the hospital. You have to give a report to the hospital. You have to tell them what to expect. Whether it's a large hospital or small, it doesn't matter. They need a heads up in case they have to round up more staff, in case they have to clear out a bed in order to bring in a new patient, whatever they have to do to make preparations. In fact, the worse the call is, the more important it is that you call sooner. But I will say that every hospital is going to be a little bit different about when they want you to call. A big hospital like UAB, they may want to know 5 minutes before you get there just so they know you're coming, because they've got all the staff. Everybody's there. They can handle anything you bring in. Just let us know you're coming. Whereas maybe a smaller community hospital, I know we worked in North Baldwin County for a while, and that community hospital there, they wanted, if you were on the scene of a bad wreck and you were 20 or 30 miles away, call them as soon as you know you're going to need a surgeon, or as soon as you know you're going to need something important. They want you to call them from the scene. And then when you get really close, you may call them back and give them a more detailed report. So wherever you're working, you'll work within the parameters that your hospital or hospitals want you to do. But you will always have to call to give them a heads up.
Is that normally the driver? About what? Who? You're
No.
too busy doing.
More times than not, it's more commonly is going to be done by whoever's providing patient care, because they're giving the patient care information. You're en route with, you know, whatever the status is of your patient. So whoever's providing care usually is going to be the best person for that. But there will be times where the person providing care or people providing care in the back are so busy they can't, and they may just holler up and say, "Can you phone report? Tell them we've got blank." And sometimes it's just that we're coming in with a cardiac arrest, and that's all they need to know, or you know, a bad trauma or something, and say, "We'll give you the best information that we can." So that's a good question. When you're phoning in that report, You're just giving him the important stuff. You're not giving them, you know, they ate 2.5 hours ago. They don't care about that. They're going to want to know if they're going to surgery, but they don't want that over the radio. And you don't want to tie up the radio line with that. Even if you're calling on your cell phone, those people are busy. Well, most cases. Some cases they're busy. But they don't, if you've got a lot of patients in there, they don't have time. So you should be able to give a radio report in 45 seconds to a minute. You give them pertinent information and get off and get out. Now they may have questions for you, so you've got to be prepared to answer any questions. So you've got to have all your information before you call. As I mentioned before, when you call in on that radio, you want to make sure that whoever answers the phone can take that report. You don't want to give this minute-long report and then they say, well, let me go and get so-and-so. So I always would ask, this is Unit 378, can you take a patient report? And they're going to say yes or no. They may say, wait a minute, let me get a pen. See, that's important. If you like rattle off all this stuff and they don't have their pen, they're not going to get a very accurate report. So, can you take a patient report? Yes or no? Don't say yes or no. They should say yes or no. Give me a minute. Okay, parts of your medical report. You want to tell them who you are and what your level is. The last service I was with, we were all ALS. The whole county had to be ALS. That was part of our charter. So we didn't have to tell them we were ALS. But in other areas, you have a tiered response where you might actually be on a BLS truck where you might have 2 EMTs on there, or maybe an advanced in an EMT. And that's an important distinction because they're going to expect a different level of care based on what your provider level is. You want to tell them how far out you are. Most of the time I worked with the same person that I was used to, and they know that I always like to call report at 10 minutes. And if I hadn't called report, they would say, are you going to call report like today? So make sure you call in a certain time frame, whatever it is you're supposed to be. Give your patient's sex and age. You know, you'll just get in the habit and say, we're en route with a 87-year-old female. So you just spit that out. En route with an 87-year-old female, chief complaint, chest pain. And then give a quick history. Patient complains of severe substernal chest pain, rate 9 out of 10. We've given 2 doses of nitroglycerin. Her vital signs are all within normal limits. Her, EKG is whatever it is. She's had 3 open heart surgeries. You might say they are alert and oriented, or they're not. Patient has diminished mental status. You're going to give baseline vital signs if they're out of normal parameters. I would usually say vital signs are within normal limits, or vital signs are good except blood pressure is blah, 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 blah. So they can quickly identify what's out of the norm. Pertinent findings of a physical exam. If it's a trauma, you may say we've got diminished breath sounds on the left side, significant bruising, or we note a small caliber bullet wound under the armpit, whatever your significant physical exam is. And then what you've done for them. Place a patient on 15 liters of non-rebreather. Pulse oximetry reading has risen to 98%. Patient is responding well, gotten better, gotten worse, whatever it was. And then medical direction if there's anything that you specifically need. Sometimes you may be calling for orders. You need orders to give nitroglycerin or oral glucose or whatever it is. Medications, the patient-assisted medications that will be given as an EMT, we have to get orders to give. So, all of our medications we do, so except oxygen. Now, sometimes you may call the hospital because you do need to get some orders from the physician there. When you do that, you've got to be sure you've got all the information that you need. You can't just look at somebody and say, oh my gosh, they have a rash all over, they got anaphylaxis. You pick up the phone, you call the doctor, and they're going to say, what's the blood pressure? You're going to go, I haven't gotten it yet. Okay, call me when you get it, and hang up on you. So make sure you've got the information that you need before you call. You want to give a very brief description. It's kind of like the report that you're giving to the nurse, but you're asking specifically for some orders. Now, you usually want to speak to the physician directly. There may be a circumstance where you may get an order from a nurse, but we are working with physicians, so the order really should be coming from a physician. If the order that they give you seems inappropriate, Like you've got a patient with chest pain, you've asked them for orders to give nitroglycerin, and they come back and say, well, go ahead and give the patient, you know, a whole tube of oral glucose. What? Or you know that you can give up to 3 doses of nitroglycerin, and they say, you know, give them up to 5 doses. What? So you may have to question them about that, and we'll talk about that, you know, more as we go through too. How are we doing so far? Okay, your verbal report. This is the one you're going to be making at bedside. You know, we've called the hospital, we've given them the report that we're on our way there and really the pertinent patient information. Once we're at bedside, we're going to give them, is that where we are? Yeah. Once we're at bedside, we're going to give them a more thorough report. I always like to ask a person at bedside, are you the person that I gave my radio report to? If they say yes, then they've already heard, you know, a significant portion of your report, and then I'll pick up where I left off. If they didn't get the first report, they've only been told you've got a patient coming in room 17, of which they might know it's a medical patient or a trauma patient. They may know nothing about it. So in that case, you're going to have to start all over and give them a review of that. So first thing you want to do is introduce your patient to whoever you're giving a report to. Number one, that's polite. But number two, it's going to help set your patient at ease. You know, we talked about how anxious they're going to be. Probably before you've gotten there, when you've given your patient report on the radio, sometimes they will go ahead and assign you to a room, and they may go ahead and tell you the nurse that's going to be there. If you are working in a very small hospital, you know who's working there. So you may say, en route, say, well, when we get there, I'm going to introduce you to Susie, Miss Jones, she's going to be your nurse, and blah, 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 blah. But when you get there, you want to introduce them so that they already start forming a relationship. You're going to give a complete report as well as a detailed report. They haven't heard it before, you're going to start from the beginning. And you might include the patient in this, you know, say, Mrs. Jones told me that she's, you know, been taking her nitro or whatever, and is that right, Ms. Jones? Yes, I took whatever it was. So that's always nice to do that. You'll give the chief complaint, history of present illness, the results of your assessment, the pertinent parts of that, including pertinent negatives. Who can tell me what a pertinent negative is? This is an extremely important phrase that you're going to have to know. Well, you can break it down. What does pertinent mean? Something that's important. What do you think a negative is? Yeah. Or what about something, say if I auscultate your breath sounds and I don't hear any wheezing, that's important. Negative. That's something I didn't find. So pertinent negative is something important that you don't find. If you have a patient with respiratory distress and you auscultate and the lungs are clear, you didn't find wheezing or rhonchi or rales or any one of those breath sounds or stridor, those are pertinent negatives. It's important that you didn't find that. The lungs are clear. That's a really good sign. So now we know that there's something else going on for them to have respiratory distress. If you have a patient with chest pain and they're not having respiratory distress, that would be a pertinent negative because you often find those two together. If you had a patient with anaphylaxis and they were not having any respiratory distress, but they had a critically low blood pressure, then not having respiratory distress would be a pertinent negative. Does that make sense? So a pertinent negative is something that's important that you might have expected or would not have been surprised to find that associated with your diagnosis, but it's not there. But by not recognizing that and mentioning it or not documenting it, it means that you forgot to look. So that's not ever good. You want to tell them what treatments you gave the patient, what you did, your interventions, and the patient's response to that. And you want to give them a complete set of vital signs. You'll give them your most recent vital signs, but if it's different, if your vital signs have changed according to your trending, you want to give them all of those vital signs. Now, you will have those written out on your patient care report that you will leave a copy of there, but if you're showing a trend, you need to report that trend in vital signs. Okay. What time is it? Y'all doing all right? Okay. Interpersonal communication. What kind of communication is that? Between one person and another. Interpersonal communication. As I mentioned as we started tonight, we communicate with a lot of people. We have to be very good communicators. If you're not a good communicator, you need to go and be a radiologist or an anesthesiologist or somebody that doesn't talk to any people. If you want to look at a microscope all day, that's good. But to do what we do, you have to be a good communicator because we talk to so many people. And if we're not clear at any point or we misunderstand, our patient could have a bad outcome. So our team communication, who do we communicate with as part of our team? Okay, yeah, other people, other services, other agencies on a scene.
Partner,
Your partner, yeah.
bystander,
ER, bystanders,
Dispatch.
dispatch,
the patient.
the patient,
Caregivers.
family members, caregivers. Yeah, there's a full range of people that we have to be very good communicators with. Of course, they're all up there, right? You always want to be truthful with everybody that you speak with. You want to be respectful. Probably one of the things that I see the most where I don't think as a group of people we're really good communicators sometimes is we don't interface well with other agencies on scene. And some agencies are better about it than others, but sometimes you kind of get in that, for want of a better term, pissing contest. What would be the better word for that?
Competition.
Yeah, where you get real competitive, where, you want to be the big man on the scene. And it's very important that we work together because if you have, say, law enforcement that's taking the lead on your scene in a not very productive manner, you could see that patient care could suffer. If they say, no, you can't go in there because you're disturbing evidence, then you can have a patient care issue there. If you don't work well with the volunteer fire department, then they may not give you information that you may need to know because you've made them mad or you're routinely rude with them. But all of these other agencies, at one point or another, they're going to save your bacon. So if you treat them badly, you're going to pay for that later. So it's important that you understand that you're all part of a big team and that you work together and have mutual respect. I probably see the thing that I've seen that most commonly is where you get the ALS unit that comes in behind the volunteers or even a BLS unit. And they're kind of rude to them, like, what you do is not important like what I do. Wrong. It's all very important. So always be polite. I always like to go in if I'm taking a report from some first responders on scene. I want to stop, provided the patient's not real critical, and talk to them, tell me about what you found, write down a report. Now certainly they're going to give me vital signs. I'm getting my own set of vital signs. I'm not relying on anybody else's vital signs, and I want you to be the same way too. So I'm going to take that, I'm going to write it down, because it may be pertinent down the road. I say, well, the guys on scene, this is what they got. I got something different, but they did get this. It may be pertinent, it may not. But it's important that you're respectful because you will pay for that at some point down the road. You're going to get people that aren't going to want to work with you. They're not going to help you on scene. And law enforcement is one group of people I definitely don't want to alienate. But they also don't want to alienate us. I've been involved with two, officers' shootings when we were down in Baldwin County, and they were very glad to see us. They were very glad that they always treated us well because, when that guy went down, they're glad to see us. So it's important. When you go down, you're going to be glad to see them. When you've got somebody with a gun in your face, you really want law enforcement to like you that day. So if you don't behave well for any other reason, just realize that at some point it's going to be tit for tat and you're going to pay for that. So always be respectful. Treat everybody else like you would want to be treated. Therapeutic communication. Now this is kind of interesting too. When you think about therapeutic communication, that comes from like therapy, right? Sometimes the way you communicate is going to have a big impact on the well-being of your patient. I remember one time I had a patient that was freaking out. I can't remember what was going on, but she was just just almost couldn't breathe. She was so scared. And she goes, you know, she's freaking out. Am I going to die? I'm going to die. Is this going to happen? I said, you know what? Just take a few deep breaths. When you see me panic, then you can panic. In the meantime, we're just going to keep nice and calm. When I freak out, then you can freak out. But some people freak out all the time anyway, so that's not very productive. So if you keep calm, then you really are providing therapeutic communication for your patient. It's important that we maintain control and keep our cool when things are falling apart around us, because we oftentimes can keep that from happening. All right, with a patient, it's important that you use your eyes as a communication tool. When you speak to a patient, you need to use eye contact. If you come in and you start asking your patient stuff, like say I'm coming in here, I'm going to do an interview of Ashlyn, and I say, well, tell me about your chest pain today. I'm looking at all the stuff you got in the room, you know, you got any antiques, you know, what's your rug look like. I'm doing everything else at making eye contact with her. What's she thinking?
That's wrong.
Yeah, you're not listening. You don't care. So is she going to open up and give me the information I need? No. She knows right away I don't care. So eye contact is very important. Shows that you respect them. It's also comforting for them. They've made a connection here. They're starting to bond there. A patient that bonds with you is going to give you good information. So it's important that you do that. Patients that bond with you do a whole lot better than the ones that you've turned off for whatever reason. Know that your body position and your body language is very important. For instance, I told you guys early on, was ER another class recently, you know, if I come up, as your instructor, if I come up and I get really close to you, is that kind of changing the way you feel? Yeah, it's kind of scary, isn't it? I'm bigger, I'm standing over you, plus that stress, like she's going to ask me a question, right? But your patients too, if you want them to know by your body language that you care. If you come in and you stand like this, you know, what are they thinking?
In a hurry.
Yeah, I don't need to be here. I'm not interested in what you have to say. I'm kind of giving that I'm the boss here, and we're going to do it my way. But if you come in like this with your hands, excuse me, I'm going to spit on you. If you come in kind of with your hands open and you have that open feel about you, and you're making eye contact, and you're not coming across real bossy and know-it-all, they're going to be more likely to open up to you. I'll try not to like do that for them and scare you with that. But you get the picture there that how you present yourself and your body language has a big impact on your patient. It's also a great idea to kneel down. If your patient's sitting, then you might sit next to them or kneel down in front of them rather than standing over them. I told you guys early on about my old partner Tilly, who was like this giant man. I'm telling you, he scared me just right into trouble with him. So yeah, when he would come up with a patient, he always needed to sit down. And he always had to really work to soften his face because he was so scary. Use appropriate language. Now this is really important, that you speak with the patient on the same level that they're at. By virtue of what we do, we're going to encounter patients from, you know, newborn to 110, to people that are highly educated, particularly in this area. You know, you've got professors, doctors, physicians, all sorts of people on the higher end of education, but you're also going to get the guy that has a 3rd or 4th grade education. You're going to get people that speak different languages, that have different religious backgrounds. So you've got a wide range of people, and you need to meet them where they are. You know, if you're talking to somebody with a PhD, you can use all those big words that you know. If you're talking to some little old granny, she's lived her life just fine with a high school education, you don't want to be talking about, are you diaphoretic? You know, have you had any emesis today? What? You know, you have to use language that they understand. And don't try to lord big words over them, because it intimidates them. When they're intimidated, they're going to clam up and they're not going to tell you what you need. So that's what we're there for. We're there to bond with our patient. You need to be honest. You need to develop a good rapport with your patient. If they feel like you're not listening, you don't care, they're not going to tell you anything. And they're going to embarrass you terribly when you get to the ER. They're going to tell them things that they're not going to tell you because they don't like you. And one other thing, I shouldn't say this, but I always say it because it's so important. If your patients don't like you, what are they more likely to do? Sue you. Regardless of the quality of care that you gave them, you could be the best provider out there. If they don't like you and they have a bad outcome, they're going to sue you. There was a guy I worked with down south here that he was a great paramedic, but I was so disgusted with him as a person that it'd have to be a cold day before I'd want him to treat me. Even though I know he was best in the business, he was very, very good. But he rubbed people the wrong way because he was so confident that he was rude. So yeah, patients like you. You can be the worst provider out there, and I hate to tell you that because I don't want anybody to think they can be the worst provider. But you can be marginal. If they like you, they trust you. So the point here is not be marginal, but your patients, they need to like you. How are they going to like you? They trust you. They feel like you're confident, you know what you're doing, you're polite, and you're respectful. Did that sound bad? Okay. Always use your patient's proper name until they tell you otherwise. I don't usually have a problem with people using my first name, but some of the older people, they want to be called Mr. Jones or Mrs. Jones or whatever. Even some younger people. So make sure you start out being very polite, very respectful. And if they say, well, call me Marge, if you're okay with that, you can call her Marge. Listening is probably the most important communication skill you can develop. You know, like your mama told you, got 2 ears, so you listen twice as much as you talk. You remember hearing that? Some of you probably didn't hear it. I can tell. I'm just teasing. But yeah, you're listening because there's really not a whole lot you're going to tell your patient that's going to alter their care or their outcome. What's going to make the difference in their outcome is what you learn by what you hear, and then you turn that into some type of care that you provide. But you need to hear what your patient has to say. If you ask them to continuously repeat something, what do they know? You're not listening. So get in the habit of writing it down. I always carry a little pad and a pen, and I'll write down important stuff that they tell me. And what does that do? I don't forget because I've written it down, and they know that you care because you're taking the time to write it down. So it's a great technique for you. It establishes trust.
I hate when the waiters don't write down orders. Like, you're going to get it wrong 90% of the time they're going to
Yeah, half the time they mess that up.
I don't know, I think it depends on how the people.
Oh, no.
I
I think it
work
makes
in a
me angry
restaurant,
every
and I know my
time.
brother remembers orders, and I think it impresses people if you can just take the order and then come back and then it's done properly.
Yeah, but you know, a lot of times they don't get it right. And it's like, if you'd have written that down,
And I tell
we
them
wouldn't
that.
be here.
I'm like, excuse me, you want to write this down?
We get a lot of people like that. You gotta learn to smile and be upset when you're
Yeah.
can't see you.
Well, the only thing is if they walk off, you know, they've not written it down, they walk off, then I'm going to be bothered the whole time that they're going to get it wrong.
Exactly.
Whether they get it wrong or not, I'm worried that they're going to get it wrong. So fake me off. Tell like you write it down, smile.
Yeah.
I don't care if you write it down. I think you're writing it down. It's the difference in I like you. I don't know how good you are, but I like you, right? Okay. Special considerations. You're going to have patients that don't, you know, meet the mainstream sometime. You can have patients that with mental handicaps. They may have visual impairments. They may not be able to hear well. And it's not all just old people that meet that criteria. You have people with language barriers. So make sure that you alter your communication style, that it suits their communication style. You got little kids, you know, you're going to approach children completely differently. You're going to say different things to them than you would for an adult. So we'll talk about those when we get to the pediatric chapter. Okay, your patient care report or pre-hospital care report. This is a legal document where you document your entire encounter with the patient. So it's important that you are very precise and accurate in your documentation. If you have to go to court later on about a call, and believe me, it doesn't happen the next week where you say, yeah, that was last Tuesday, yeah, I remember what happened. It's going to be years later. It can be 5 years later when you actually go to court over something. And if you've worked in the business for a while, particularly in a busy service, you're not gonna remember these little piddly calls. And some of them are not so piddly, but you're not gonna remember specifics, and they will rip you apart on the stand. And all you're gonna have is whatever you've written down. So with every patient, if you will think, if I had to go to court over this call, does this run report tell me everything I need to know about this patient encounter? If you can say yes, then you've done a good job. Some of your calls that you may be called on legally may be a really serious call. Like I've had to go back after, you know, a couple murders that I was on. With those, I documented it very well. But I've also been called in for little piddly calls. One was a call down Gulf Beach Highway, and it was a taxi cab that barely touched this other car. Well, about 3 or 4 years later, there comes this lawsuit where this guy said he was really hurt. Well, they sent me a copy of my PCR, and, you know, y'all don't know this about me, but I'm very AR. And so I had this very thorough patient care report over a nothing call. And fortunately, the attorneys were able to look at that and say, there's nothing here. Everything was documented so well, they don't have a lawsuit, so don't even worry about it. And I was good with that. So with every call, you need to know that you've documented well enough that you're going to cover yourself if you have to go to court with that. So your PCRs, you may handwrite them. There are probably some areas of the universe where they still handwrite these. In the state of Alabama, you have to submit a digital copy of your PCR to the state office within, I think it's 48 hours. So somehow your report is going to be digitalized, whether you put it in that format to begin with, which that's most of the cases, but there's still one service that's a national service where they actually call in a report over the phone, and somebody there is like taking dictation, and they type it all up, and they send it to you digitally for you to review it, and you okay it or make changes. But here in Alabama, most everybody uses some kind of a laptop, and they submit it that way. They're kind of handy. In some ways it makes it easier, in some ways it's more cumbersome. As I mentioned before, that your patient care report is a legal document. You're going to be documenting your findings, the results of your assessment, all of your vital signs. You also will write a narrative, and that was talked about, you know, you did that little documentation video. You're going to write a narrative that essentially paints a picture of your patient encounter for people that weren't there. Now, I mentioned to you the other day that at the emergency department, they can't see how your patient was found. They can't see the damage to the vehicle. They can't see if the home was warm or cold. They can't see the state of that home. So there are a lot of things that they won't be able to see unless you paint a picture for them so they can get a full picture or idea of what's going on with the patient. You know, with anybody or anything, if you just take a little slice, it's kind of like a CT scan. If you just take one little picture of one little slice, it doesn't tell you a whole lot. But if you put it in the perspective or in the context of all the other little slices, then you get a whole picture, right? Same thing with us. We have the patient in one sliver of time. Emergency department has them in a sliver of time. You know, the allied health, you know, radiology and all those others, PT, they have a slice in time. So it's important that for all those others to see the big picture, that we do a very good job with our PCRs. So I said it's a legal document. It can be subpoenaed. It can be used as evidence. So what you write is very important. You do not want to be on the stand and be very embarrassed because you've written a really poor document. One case out of Florida a few years ago, Pinellas County, as a matter of fact, the paramedic had a guy, had a patient, and he wrote on his PCR, here it is. Let's see. All right. Y'all tell me what's going on with this patient. That's a D. Son of a... Don't say it. Okay, this very experienced paramedic wrote this. This was his entire PCR, his narrative of this patient. This says 87-year-old male, SOB, FTD, NIT-BOMA. Y'all all know what that means,
I
right?
don't know what that
Yeah. Nobody on earth knows what that means. This guy made that up. And so that's poor if you put that in on a patient care report because nobody knows what it means. And so the attorneys are going to like rip you to shreds with that. So 87-year-old male, short of breath, fixing to die, not in the back of my ambulance. Yeah, I'm telling you. I taught the EMS law class. This was a case. It cost Pinellas County $6 million for this.
I thought we were gonna call none of them being.
I know that's pretty good. There was another about that. I'm not
You're
gonna go into
serious,
it.
he really put that.
Cross my throat, hope to choke.
Not
I'm
in
telling
the
you.
back of my.
Not in the back of my ambulance, nit moment. But the sad thing about this, I mean, it cost the county $6 million, but the care provided for this man met all the criteria. He provided good standard of care, did everything right.
Just no documentation.
This crap cost the county $6 million. Bad.
So you had to stand up in court and admit that it stood for not in the back of my ambulance?
Yep, that's exactly what happened. If he could even remember it. How am I doing here?
Oh, that court's on video on YouTube.
Ta-da. Yeah, so it's important that you document well. There are a few others I won't go into now, maybe sometime in one of the labs. But recognize that you may have a patient that needs your documentation because he did get some bad care. And it may be the other side of that. So it may come down on either side. In most cases, we are not the defendants here. In most cases, we're just there to support, you know, one side or the other. But your documentation may indicate who's going to actually win that one based on what you put. But it can be used against you in the case of negligence. So always make sure you document. Now, you could be sued for negligence if the patient had a bad outcome because you failed to recognize, assess something, and failed to treat it appropriately. You could be found negligent. However, if you document that you looked for that, you documented that pertinent negative, right? And you made your assessment based on that, then you'll clear yourself. So if you did it and you didn't document it, it's like you didn't do it. So make sure you document that. Stay away from that NIT-BOMA thing. Also in your PCR, there's an administrative section which will have all your demographics. Your demographics, you know, your patient's name, his address, sometimes it's a social security number, all that important identifying information. This is going to be used mostly for billing, for identification purposes, but for billing so they can bill for the insurance. You can give patient information for billing purposes. Also in the PCR, they're going to use that for education and research. Every month, your medical director probably will pull one type of call or another. One month he may pull all the cardiac arrest calls. Next month he may pull all the shortness of breath, one allergic reactions, you know, one some type of respiratory distress. And so he'll check those and see how is his service doing. Are you doing what you're supposed to do in each one of these types of calls? The state level, the reason we have to submit our PCRs there is so they can do research on that. How are we doing as a state? Are we responding appropriately to chest pain calls? What are the outcomes of those treatments that we're providing? So on the national level now, and all this stuff is culled and sent nationally, so we can really do research on the treatments that we're providing. In the olden days, we didn't have that ability. Now we do. So it's important that you're accurate because they're going to use it for research and education. You can also use it to track your own, how you're doing. You know, at the ALS level, if you're only intubating a patient once or twice a year, you are not staying competent. So you'll know that that's something you need to work on. Your medical director will know that that's something you need to work on. So that's important. Quality improvement, your service should be having meetings once or twice a month where they're gonna go over the calls, who's doing good, who's not doing good, how you could have done it better. Make sure that you're adhering to the protocols, that you're adhering to the standard of care. Very important. You're also going to have rundown on there. All of your times are going to be in there. And these are listed for legal reasons. The time that the 911 call came into the dispatch center, the time you were dispatched, the time you arrived on scene, the time you left the scene, the time you get out at the hospital, and then the time that you're turned around, we call that 10-8, you're back in service. So there's a whole accumulation of times that are very legally significant. Say you had got a call from here to the bread pub. We're here, you were here hanging out doing a demonstration for the class or something, and you get called to the bread pub, and it takes you 15 minutes to get there. Patient has a bad outcome. So they can see on there it took you 15 minutes to get there. Can you explain away why it took you 15 minutes to get there?
Yeah.
What?
Car wreck, or another car wreck, or something, the traffic.
Yeah, it could be fog, it could be a tornado, it could be the train blocking the way. So if you have some extenuating circumstances, you want to make sure you document that. You know, we had a train delay of, 8 minutes or whatever it was. So you want to document that if it's out of the normal parameters, so that, if they try to sue and it shows it took you 15 minutes to get there and you don't give a reason for that, you're SOL unless your lawyer is really good and pulls all those dispatch tapes and pulls the train schedule, or, tries to line that up with, what the state troopers say, what was going on that day. So that's going to be part of your time report also. You're going to give your agency date, all of your times, who's on your unit, what the certification levels are, anything else that's required on that form. All of your times, I already said that. Your patient demographics, any information that you gathered. Then you're going to go down and give results of your assessment. There'll be areas where you'll just put all of your vital signs. There'll be areas where you're going to put any drugs that you gave. Another area where you'll draw your picture, do your narrative. And that's mostly what you guys are going to focus on your documentation that you're going to be doing on your guys. There are several ways that you can document. You're going to document your objective assessment. What are going to be the things that you're going to document in your objective assessment? Y'all know this. Do what? Your vital signs. Yeah. Think about the difference between objective and subjective. We talked about the difference between signs and symptoms, right? So you'll have one place where you're going to document all your subjective, which will be all of your signs, your vital signs, the results of your physical exam. And then you're going to have your subjective part. So we're going to say what your patient told you. Patient said he's got chest pain 8 out of 10. Patient reports that he feels nauseated. He's thrown up 3 times a day. All that stuff is subjective. So you'll have 2 separate areas that you'll be documenting that. You will always document their chief complaint. I always like to put quotes in there. I'll probably, in any patient care report, I might have 2 or 3, maybe more sets of quotes in there. A quote, if you have to go to court, a quote is like the patient is standing right there saying it. You just can't do any better than that. Patient states, quote, "I only had 2 beers," end quote. Patient states, blank, 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 blank. When he's given his chief complaint, I like to put the patient quotes there. You just can't do any better than that. Make sure that you, if you document a quote by somebody else, just say, family member states, bystander states, quote, "I saw him run off the road and hit the tree," or "I saw him slump over before he ran off the road." I'm going to put that in quotes. You want to document any pertinent negatives. If you don't document that you didn't find it, it looks like you never looked. In your narrative, if you don't know the official medical terminology for it, use plain old English language. You don't want to say the wrong thing, and you don't want to sound stupid if you spell it wrong or you misuse the term. So Be as basic as you need to be to make sure you get it right. If you're writing it out, make sure it's legible, make sure it makes sense. Always go back and reread anything that you've written. Before you send out an important email, you need to reread it. But particularly here, because this is a legal document, make sure you reread it. The PCR and your documentation is a reflection of the care you provided. That the Pinellas County thing, that reflected on him as a poor care provider. But his partner said yes, he did everything he should have done. I mean, there was evidence that he started IV on this guy. There was evidence he had given the proper drugs, but he didn't document it. It made him look like he didn't know what he was doing, and he gave poor care. If it happened, to record it. If it didn't happen, don't say it did. There are some special documentation occurrences. Make sure that you are very mindful of your patient's confidentiality. Don't put anything on there that's not true. Make sure you keep your documentation secure. If you're writing it out, it needs to go in a sealed or a locked box after you finish it or while you're still working on it. Refusals, we go to court more over refusals than anything else. Usually where we've left a patient that we should have transported. There's very high liability on our part with refusals. That's why we spent so much time talking about refusals. You want to document everything about that refusal, why the patient refused, the steps you went through to convince them that they need to go. What would be some steps that you would go through to convince a patient they need to go to the hospital?
Tell them what could happen to them.
Worst case scenario, have them talk to a family member so the family member can talk them into Jim and Elliot. I'm sorry?
Have them talk to
Have them talk to the emergency department physician. What else? Try to find out why they won't be transported. Is it a money issue? You know, is it they're worried about their dog? Find out why they won't go. What else you need to do?
make them sign a refusal if they say no after every
If possible, you want to get them to sign a refusal, and who do you want for a witness? A family member would be best. Yeah, somebody that's not going to lie for you. Well, actually, we always like somebody that would lie for us, but they're not very credible in court. Also with the refusal, you want to tell them what to look for. You know, this is what's going to happen if you're getting worse. So make sure you tell them. Make sure you tell them they can call you back. If you change your mind, call me back. So there are a lot of things you need to document that you went through on that refusal, and all this is to, what's the acronym? CYA? Yeah. I didn't say that. Falsification. Make sure you're completely accurate when you do this. Don't write anything that's not true. It may come back to bite you. You don't want to falsify something in order to cover up an error, because that error, your patient could have a bad outcome from that. So legally, the way everything is moved in healthcare is if you will admit you made a mistake, because we all make mistakes, if you'll admit it, you know, you'll be okay. The problem comes in trying to cover it up. It's like that in government. It's like that everywhere. If you admit your mistake, we can forgive you. If you try to cover it up, we're going to crucify you. So if you made an error in your PCR, that's okay. You recognize that, then you take steps to correct that. If it's a handwritten thing, then you go back and you do one single strike through there, and then you write in the correct thing there. You may add an addendum to your either your digital report or a handwritten report, so you can correct that. And you say why you forgot. You know, we had 15 patients that day, and I accidentally transposed these numbers, but I recognized it. Okay, here we go. You respond to a call for an unconscious male. Upon arrival, the patient is awake, alert, and walking away. Okay, so he's really not unconscious anymore, right? He states he was just sleeping. He doesn't need or want treatment or transport. Okay, so you got a picture of this guy? Is this a patient? He says, what does he say? He was just sleeping. He doesn't need or want treatment or transport.
No.
Is he a patient?
He's Somebody
All
told
we
me.
know is
Yeah.
Somebody called.
He didn't call 911.
Yeah.
I didn't call 911. There's nothing wrong with me. I don't need you here.
There's no mechanism of injury listed.
He said he was sleeping. Is this a patient? Probably not. Is a complete assessment and physical exam needed here?
No.
How will you document this call? Yeah, patient stated he was sleeping. Now you probably need some type of foundation. You need to be able to report that he was alert and oriented, that he had a legal ability to refuse, right? If he is drunk, he can't just legally refuse. You need to be sure that he's really okay, he's just drunk. And sometimes that's the case. You know, if this guy was asleep, he'd had too much to drink, and he gets up and wanders off, you know, you don't see any evidence that he's been injured in any way. Nobody reports, I saw him fall down the steps. If he will submit to you and allow you to get a set of vital signs and do a quick assessment, then you want to do that and document that. But he has the ability to refuse and say, don't touch me, I'm not interested. I was sleeping, that was a mistake, he's not a patient. You just document everything that transpired, because if a few hours from now he turns up at the ER and he says, or he has a bad outcome and they say, well, the unit responded out there to him and they didn't transport him, you got to document, that he was alert and oriented, that he was of sound mind and body, that kind of thing. Should you obtain a formal patient refusal?
Yes.
If I can, I will. Sometimes you can't. Special reporting situations. Sometimes you may have a multiple casualty incident where there are a lot of sick or hurt people and you have limited resources. In this event, whole new laws come into play. We have different reporting situations. This is a this is a triage tag. If you've got, say, 8 care providers and you've got 30 patients, there's no way you can take care of all of them. So you have to triage them. One person will come through and determine, or they have a minor injury, like they twisted their ankle. A delayed might be they have a broken arm. Immediate, they have a respiratory distress or altered mental status. Deceased or nearly deceased means they're not salvageable. You don't have enough help. You got too many patients. So what they do is they tear off wherever it should be. If you see this whole tag, they're going to be the one that's showing. If they're delayed, like a broken arm, they'll tear the bottom one off and they'll be listed as delayed. Respiratory distress, they'll tear those 2 off. But most of the time you're not going to have a patient name on here. You won't have other specifics. You'll just jot down whatever made you determine that they were whichever level you pick, and you'll attach this to them some way. But these, it can be very challenging in a multiple casualty event to get this thing managed. Down the road, in the semester, we're going to look at how to triage a patient. We've got criteria that we're going to use to triage a patient. Other special situation reports, anytime you have an exposure. When we talk about exposure, we're talking about where you've had an exposure to some type of communicable disease. That's what we mean when we say exposure, not that you've been out in the sun too long. Anytime a provider's been injured, you're going to have to fill out paperwork about that. Any hazardous or unsafe scene that you might have been on or exposed to, or that might have had a bad impact on the patient, you'll need to document that. If something on the scene put you in jeopardy, for instance, one of the other agencies did something that was unsafe, grossly unsafe, you need to report that. Referrals to any social services. This might be if you recognize child abuse or you suspect child abuse or some other reportable, or rape, something like that, you're going to have to report that. That would be a special reporting situation. Pretty quick. Okay, radio report should include what? Yes, first who we are, the patient's age and sex, when we're going to be there, ETA, chief complaint, history of present illness, basically.
Mental status.
Yeah, probably want to tell them if they're alert and oriented or not, their mental status. Results of your assessment, any treatment that you've provided.
Response to that treatment.
Yeah, and the response to the treatment. Let's see if we got all that. who you are, when you'll be there, patient's age and sex, chief complaint, pertinent history of present illness, major past illnesses if it's relevant, if it's pertinent. You know, patient is complaining of abdominal pain. He had his appendix taken out 10 years ago. That's important. Their mental status, based on vital signs, any pertinent physical exam findings, what you've provided for them, and if you need any med control. PCR should include the patient's name and address. Y'all don't leave yet, okay? We're here till 10 tonight. Okay? All right, so y'all can pay attention to write notes, just a little bit longer here. Their specifics like their age, their sex, billing information, nature of call, mechanism of injury. You're going to have to document that too, what you were called for. And it's not always the same as the patient's chief complaint, right? You may get called for altered mental status and you get there and it's chest pain, or vice versa. The location where the patient was found. This is important, say, in a car wreck. Where was the patient found? At their home. Were they in bed? Were they laying on the floor? Were they standing up walking around? Were they standing by the mailbox with a suitcase in their hand? You know, where were they found? That was a joke. No one's laughing. You'll appreciate that later. They call 911. They're ready to go. They've got their bag and everything. My bags are packed and ready to go. Okay, any treatment that was done before you got there? You know, did they self-medicate? You know, did somebody else provide some kind of care? Legal document in court. The data may determine future treatments, how we're doing as a service, as a profession. Your report should paint a picture, and from start to finish, you want to describe your patient in such a way that the ER physician can read it and know about that patient. Very, very important. Remember to review your radio technique, that you are clear, that you communicate well. Before you make that radio report, make sure you've given some thought to what you're going to say. If you've ever had, you know, did you ever take speech and they give you a topic? You know, you don't want to just stand up there and just start foaming at the mouth about some topic that you don't know anything about. So it's important that you organize your thoughts, because they want it in 45 seconds or a minute. If you start stuttering and blah, 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 what are they going to think about you? Not very bright, not very competent. So try to get organized. It's a hard thing to do. We'll practice that in here. We've got some little radio things. And I've got a format that I've got written out. And so early on, you may fill in those little blanks. And then when you're ready to make your report, you can just read right off of there until you're used to spitting it out without having to read it off. So remind me to get that to you. Bedside report. Yeah, I already talked about that. How can you improve your interpersonal communication with patients and team members? Y'all just think about that, okay? Tell me how you figure that one out. What is objective and subjective information in the narrative portion? It's going to be basically your signs and symptoms, right? Okay, no, we're not going to do this. In fact, I do want you guys to do this. We're just not going to do it tonight. I've given you a bunch of information here. It says organize this random information and present a radio report to the hospital. I'm going to print these out probably one day next week, and I'm going to give you a format to go by, and I'm going to let you put that, piece it together so you can make a radio report. Somebody email me and remind me to do that. Yeah, so all this is really just a patient encounter that you'll have. Write a narrative for that call. Okay, yeah. Anyway. Can everybody sing that one? Yeah, that's pretty good. That's pretty good. Let me turn the recorder off. Here. I'm going to start talking about it.